I think that's, there's another auto here, but I'm not sure what that is. I think that's just, is that just the addition, anybody coming in? Okay. Well, welcome. This is our second pediatric echo. Our agenda for the meeting will be, we're going to do, propose to do 3 case studies. We have the presenters here, so that's great. And Dr. Xixis. And by the way, as we present the case, please feel free to ask questions. There is a chat button at the bottom. If you don't want to interrupt the conversation, you can hit the chat button and then type in. I don't have a keyboard, but you could type it in, a question, or we don't have a raise hand thing, do we? No. So we don't have a raise hand. So do that, or you feel free to, I think Dr. Xixis is fine with you, or the presenter should be fine with you interrupting if you have a pertinent question. We'll do the 3 case studies, and then as Dr. Xixis discusses it, please feel free. This is meant to be a group discussion, so please chip in questions or comments as you see fit. Then at the end of the cases, Dr. Xixis has prepared a brief presentation on epilepsy, pediatric epilepsy. So with that, Cassie, are you got your sound working there?
Yes, I finally have it. Can you hear me?
We can hear you.
We can.
The backlighting makes it hard for us to see your face.
Hold on, I can change that.
Yeah.
So the topic of this particular echo session, we were going to do a little session on epilepsy syndromes in children. There's a bunch of them, so we have divided them up, and this is kind of part 1. But Cassie Hudson did have a really good febrile seizure case, and so kind of as a transition from the last time we had our session, we were going to do that first, and then transition to a couple of kind of pediatric cases that we can discuss, and then we can go on to the didactic from that point.
Great. Cassie, would you like to present your case then?
Sure. So I had a 17-month-old male who presented to the emergency room. He had, the initial presentation was that he was just at home and was playing and was walking, and then all of a sudden fell and then had a seizure that lasted approximately 90 seconds. Mom said it was a generalized tonic-clonic all-over seizure. She wasn't sure if eyes were open or closed, and it just kind of resolved on its own. She said he didn't have any symptoms of being ill, no runny nose, maybe a slight cough, but not something she thought anything about, and she didn't notice any fever at that time. When he got to the ER, he was afebrile, but then within 10 minutes had another seizure that was exactly like the one at home, lasted about 90 seconds. Didn't require any kind of medication to have the seizure to stop, but they did notice a fever at that time of 102.3. So the ER doctor was concerned about a possible meningitis, so he did a lumbar puncture that was basically normal. He also did a CT of the head that was normal, and CBC and electrolytes all normal. So we admitted the kid just for observation, and then he had another seizure that was on our floor that lasted about 90 seconds. Our nursing staff did give him diastat, which caused the seizure to stop. They noticed a brief episode of cyanosis, was sat down into the 70s, otherwise normal vital signs, but he was not febrile at that time. They recorded 100.2. So my questions, I guess, from that case was, is this true new onset epilepsy, or is it a complex febrile seizure? The mom kind of thought that he had fell and hit his head and then had the seizure, and I thought maybe he actually fell because he had the seizure. So would you bridge this patient with Klonopin, or would you start Keppra, or both?
Sure. So I think the first really good point that you made is this just a complex febrile seizure? So kind of in thinking back about what we talked about last time in our session, kind of identifying, is this complex or is this simple, which you've already identified. And just to review very briefly for those of you who were not able to join us. In looking for a complex febrile seizure, we're looking for a seizure that either has focality, has an event that lasts over 15 minutes, or is going to be more than 1 in 24 hours. So either any one of those particular criteria is going to kind of boot you into the complex febrile scenario. And so I think you're very correct to call this a complex febrile seizure event. The story of not having the fever at home and then having it when it gets to the ED is very classic. Often we see febrile seizures occur when we're having a rapid change in temperature, technically up or down, but usually up. Usually I didn't know they were sick and suddenly they've got a fever kind of scenario. And so with that in mind, I would call all of this a complex febrile seizure because we do know that it happened in the setting of a clearly febrile event as opposed to nitpicking exactly which second he had the fever. I wouldn't get into that. I would say overall, this is a kid who has a febrile illness who is sick. I think your next point about what to do about medication is very valid. The last time when we talked about febrile seizures, we said, we often will give parents a rescue medicine in case it happens again, kind of plus minus, but we definitely don't start a medication. This is a scenario where I do think that the benzodiazepine bridging, which we had talked about briefly before, is very valid. And so in a kid who is demonstrated that when they have a febrile seizure, they're having multiple within that time frame, that's a kid that can really benefit from the benzodiazepine bridging. And for those of you not as familiar with that, when we say that, it was first studied back in the 1990s with some different versions of benzos than we typically use now. Currently, the most common one we use is Klonopin because we can give it twice a day. The administration's pretty good. The half-life is pretty good to give it that way. And we give it twice a day for 3 days during the febrile illness. So I don't know that you could have said ahead of time, I know this is going to happen, I should start Klonopin the minute we admit the kid kind of thing. But I think this is definitely a family that I would give some Klonopin to have at home. Like a set of 6 to have for a 1 round, so that if they have a febrile illness of high fever, or if they present with another febrile seizure, I'd go ahead and tell that family to do a 3-day bridge. I don't think you need to start Keppra or any kind of long-term maintenance medication. I very feel like this is still in the febrile seizure range, but I definitely think this is a really great benzodiazepine bridging candidate for sure that you kind of identified. Does that make sense?
Yes, it does. Thank you. So you're okay with just setting him up with an outpatient EEG from there?
Yeah, so from the stepping back and looking at kind of etiology for complex febrile seizure, routine EEG is an outpatient if the kid is well appearing, which it sounds like they're back to themselves, is definitely the appropriate next step. And he did have the CT in the emergency department, but I would hold on any further imaging until we get the EEG, and then we can decide from there if he needs anything else.
Okay.
Are there any other questions about this case?
I've got 2 questions, just briefly. One is, what is your threshold for, one is, was it a rectal temp? And secondly, what's your threshold for determining febrile, illness? Is it 100, or is it over 100.5, or is it lower than that? And then thirdly, a lot of times we're trying to avoid CT scans. Is this a kid you would have recommended CT in the emergency department?
Yeah, great question. So ask again if I forget any of them, okay? First, I typically will consider the febrile just like any other febrile event. So over 100.4, not lower, not higher for a febrile seizure, just the kind of the classic definition. And then, if I had, if someone had called me and told me the story before they even went to the ED, I would not have recommended a CT scan in an otherwise kid that is returning to baseline and has a normal neurologic exam. Certainly if they look like they have meningitis or they look wrong, their exam is abnormal, obviously, certainly, go for the imaging. But from a well-appearing child standpoint, it's really not indicated.
What are some of the indications or threshold for doing a lumbar puncture in a kid who's febrile haven't had a febrile seizure?
Yeah. So if they are very young, so under 6 months, which technically wouldn't really fit the febrile seizure category, but under 6 months, we'd want to think about it. Any kid who has been partially treated with antibiotics looks okay, but is kind of coming into the ED seizing, I have a lower threshold to think about that, because certainly we could be masking something. Any kid who is not appropriately immunized, especially against things that we highly see, related to CSF infections. And then any child at all who is either not returning to baseline within a reasonable, you don't have to pop back up, but you have to be trending toward normal, not returning to baseline, or has any abnormality on their neurologic exam, because that's a kid, do they have a brain tumor? Is there something else going on that I want to catch? But a kid that looks great, I would not image them first thing, no.
And I apologize, this is the last one, I promise, but we sometimes will avoid Klonopin because of abuse potential with parents. Is there a role of rectal Valium ever?
We don't typically advise it for this, simply because it would be hard to give twice a day for 3 days. We do recognize that as an issue. I only give it in sets of 6. So if you have used an entire set, we need to talk about what's going on, especially if you're not reporting any illnesses. So we do kind of keep a tight range and give an exact number on it. But if it's indicated, then we do dispense it in sets of 6.
Thank you.
Yeah.
I want to welcome actually a couple of people that joined us. Brandon Babcock from Abingdon. You're muted, Brandon.
Hello.
Did you say hi? There he is. And Gary Michael. Hey, there he is. Brandon's one of our hospitalists up in Johnston Memorial Hospital. Gary Michael from Clinch River Health Services. Can't see him, but hi, Gary. You may be out of the room right this second, but great. One quick question I had is, it seemed like this child, correct me if I'm wrong, Cassie, the first seizure wasn't febrile at the time, then I even had a second seizure, and then after that, they detected the fever. How far after a seizure do you call it a febrile seizure if you're waiting for the fever to come on?
Yeah, I would probably give it up to like 12 hours. I don't know that there's an exact answer to that. There may be a literature study on it. But yeah, if they are showing signs of I'm clearly moving toward a febrile illness within that time frame and otherwise are well appearing, then I'll give it to them.
Okay.
I think it's more likely that that's what it is than not in that setting.
Any other questions?
Anybody else about febrile seizures before we kind of switch gears a little bit toward today's topic?
Great. So the
All
next
right.
presenter
We've
is
got
that
Holly
Holly.
next.
Would you like to say your case?
All right, so I have a 6-year-old male here. He has no other past medical history besides a benign heart murmur. So family heard him up in the middle of the night, and so mom kind of followed him into the bathroom because he usually doesn't wake up in the middle of the night, so she tried to see what was going on. She noticed when he was in the bathroom that his eyes were fixed and dilated, and he was kind of staring straight ahead. He had a lot of drooling. He had some lower jaw twitching, and he was trying to talk, but he was only able to get out a few words which were slurred, but you really couldn't understand anything he was saying. This episode lasted 4 minutes. It's the only time it's ever happened, but she does note that there was one other time that she caught him in the hallway when she thought it was just sleepwalking. She kind of redirected him, brought him back into his bed. She thought maybe he was having a nightmare. That time she was able to snap him out of it. So after this had happened, she brought him into the ED. He had a CT of his head done. It showed cerebellar tonsils, which were 5 millimeters, which they termed borderline Chiari malformation. Otherwise, his head CT was normal. All his other lab work in the ED, electrolytes, glucose, all that was fine. They did not do an EEG. And they didn't do any other seizure type workup, no seizure panels. So otherwise, past medical history, he was full-term spontaneous vaginal delivery, no complications during the pregnancy or at the time of the delivery. He developed normally, met all of his milestones on time, and he's currently in 1st grade doing well. He hasn't had any surgeries, and besides that heart murmur, no other relevant history. Family history is not relevant either. There's no family history of seizures, no developmental delay in the family, and the only thing mom mentioned is a single migraine that she's had before. Otherwise, nothing else significant there. His physical exam was completely benign. So I'm just wondering, what do you think would be the etiology of this spell? Where did it come from? What is it? A little concerned that it might be a seizure, although he was responsive during the time that this episode was going on. And kind of like, what further workup would you do? Would you do a sleep study, an EEG, any other brain imaging?
Yeah, so I think this is a common thing that comes up for pediatricians, but as well as for us. Is it a sleep problem? Is it a primary sleep problem? Do you need a sleep specialist? Is it kind of a night terror, kind of sleepwalk general area, or is it something kind of epileptic or otherwise? And I think that these are kids, honestly, that could be missed very easily. When they come in, you kind of complain of this and they've taken them back to bed and it kind of went fine from there. These are actually kids, this is a pretty classic story for benign Rolandic epilepsy, actually. And I think that if anybody, myself, pediatricians, family medicine, anybody just recognizes that from the story, you can often kind of pick this one out, although sometimes it is kind of overlooked. So from my point of view, I would definitely go ahead and recommend an EEG. The things about it that make me think, oh, this fits an epilepsy syndrome, which we're going to talk about more in a few minutes. But the things about this particular case, the fact that he was mostly aware but seemed to want to talk and not be able to, that suggests that's a little strange. Awake but not able to talk. The drooling actually is a classic component of this syndrome, which is just something that you have to know off the top of your head, but that is something that for me kind of sounds more fishy maybe than if you weren't doing that. And then the jaw twitching, I think, is what would get kind of anyone onto the question of, is this actually a seizure or something else, going on causing this? So from our perspective, I would definitely start this workup as an epilepsy workup before I would do any kind of sleep study or anything like that in this setting with this particular story. The beautiful thing about benign Rolandic epilepsy is it is actually one of the very, very few conditions that you can diagnose with an EEG. So if you capture the abnormalities on an EEG while someone is going to sleep or is asleep on the EEG, there is a pattern that is very specific for it. And at that point, you can kind of say, yeah, this is what you have, in addition to your clinical suspicion. Mm-hmm. I actually had this come up with a different kid yesterday in my clinic. And what I told the mom is, some people might say, well, does it matter? Is this kind of epilepsy or is this kind of epilepsy? And it actually really matters for this particular case because this particular type of epilepsy has a great prognosis. Kids may not even need medication for it. They often don't even need an MRI. So it's a very different kind of different type of epilepsy than we usually talk about. And so that's a very different prognosis and a very different pathway than a kid who is having either not seizures or other types of nocturnal seizures, which obviously needs a normal workup, MRI, et cetera, and needs potentially medications forever. So it's a very important case, I think, to pick up the subtleties of it. The details of the kids standing there are also really important. I feel like if you had, only been able to get from mom, hey, they're standing there, and then they kind of snapped out of it, that'd be a lot less specific. But with the drooling piece, the twitching piece, the kind of I couldn't talk piece, that combination is pretty classic for benign Rolandic epilepsy.
Okay. Any questions? I'll start with one. So is benign Rolandic epilepsy considered a focal seizure?
Yeah. It is. It is actually one of the few epilepsy syndromes of childhood that is a focal abnormality. And the abnormalities that you see on EEG can be on both sides, but they can also be just on one side. And so that's where you can have essentially retained consciousness, or at least very close to.
It seems like his consciousness might have been impaired a little bit.
Yeah. Yeah. And that's very classic.
Gary, you learning all kinds of cool stuff?
No.
Gary, why don't you guys mute unless you want to ask a question? You're welcome. That's okay. Don't worry about it. So it's pretty classic to have a sort of,
you seem like you're not quite okay, but you snap out of it. That's a very classic story for a kid with a episode like this. And these episodes sometimes will go undetected in a kid with benign Rolandic epilepsy because, you know, it was sleepwalking, parents ignore it, whatever. And then they also can have generalized tonic-clonic seizures. They don't always, but sometimes a kid will present with that. And then if you look back and ask about sleeping, which is an important point, I try to ask everybody that comes to our clinic, how is your kid sleeping? And sometimes just with asking that, you can get this kind of extra story that really propels you in a different pathway in terms of your diagnosis.
Does it always present during sleep, or it can be?
Yeah. So it is. I don't want to say 100%, but sure. Yes, the classic answer is yes. The abnormalities come out during sleep. Another reason, which we referenced a little before at the last session, that when you get an EEG, kind of capturing some drowsiness and sleep time is really important, because if you've only captured awake time on the EEG, the kid could definitely have this, but we won't have captured those abnormalities. And in that setting, we'll call it awake normal. Everyone will say their EEG was normal, and we'll kind of move on, not really knowing what our diagnosis is.
Anyone else there that has a question on this particular case?
Does it always start off as central facial twitching and then kind of progress outwards from there?
Yeah, that's a great question. It typically will actually stay as facial twitching, often on one side. An older kid or a kid that's more cognizant of what's going on may report sensory changes as well, typically on the one side that's also affected by the twitching. But you usually actually do not have spread. It's kind of this quick little, I can't talk, I'm drooling, I have the twitching, they pop out of it, and then it usually does not progress to a bigger seizure. That's not the classic form.
Okay.
So what is you said that some don't require medication, some do? Yeah. And the natural history of it as well? Yeah.
Can we talk about that at the end?
Yes, sure.
Okay. Yeah, we'll go through the criteria and kind of why we think about this particular situation a little different than others. I promise.
Sure.
Sorry.
No, that's good. She's got as we said, there's a didactic portion, 15, 20 minutes.
Yeah.
Is that what you expect?
Or not end. Longer. Yeah.
Or a little longer?
Maybe not longer, 10, 15 minutes.
Okay.
Yeah.
Any other, Helen, you have a question there?
Does that have a post-ictal phase?
Typically with the form we just talked about, the drooling, can't talk, typically they pop out of it fairly quickly, and they're really not, it's the middle of the night, but they really don't have a true post-ictal. You kind of put them back to bed and that's it. Classically, people will say, yeah, my kid comes in the room and I've seen them like 2 or 3 times. They kind of stand there and they're staring at me. It's really weird. They seem like they want to talk, but they can't. They pop out of it and I put him back in bed and I just thought he wanted to get in bed with us. Like that's a very classic, when you ask about sleep, you hear that story a lot. And that patient, you can almost say, no, you have epilepsy, like, with a couple more questions. So.
Which is more common, sleepwalking or benign Rolandic epilepsy?
Well, I don't know, but benign Rolandic epilepsy is about 20% of childhood epilepsy. So it in the world of epilepsy, it's very common. I don't know in terms of like comparing number to number.
What you just described sounds like kind of a classic sleepwalking.
Yeah, I know.
Kind of go back to their room.
I know. You got to ask the right questions. Get the right answers.
That's fascinating.
Is there a correlation between sleepwalking behavior and possibly focal seizures?
Not that I know of. Not in a case of a true sleepwalker. Is there also an underlying risk? Not that I know of.
We're getting a little static coming through. So if you're not talking, just please try and mute background noise or something. Where is it coming from, Ryan? Right. Brandon, there you go. For some reason, Brandon, when you unmuted, there was a lot of static coming through. I don't know why. Maybe it's just your line. Okay, great. Shall we go to case number 3?
Pretty good? Yeah, pretty good. I think Dawn was going to present a case.
Dr. Toole, would you like to present your case?
Sounds good. I'm actually presenting the case for Helen, who's on vacation, and she didn't know if she was going to be able to join us. So feel free to add to the story if you'd like. Yeah. So I'm presenting the case of an 8-month-old male with a past medical history significant for a trisomy 21. He presented around 6 months of age with mom concerned about some jerking spells he was having. The jerking spells are described as he has extension of both of his upper extremities and sometimes has a head drop associated with it. And initially, they just thought maybe it was kind of a big startle response that he was having and didn't think too much about it. But they started to happen more frequently, and the intensity of the episodes increased over the last several weeks. The actual jerking only lasted around 1 to 2 seconds, and then he was completely back to baseline. Never knew anything happened, happy baby, no problems. Now the events are happening up to 20 times per day. They're not clustered together. They're more distinct individual events. There are not any identified provoking factors or triggering episodes. He's not on any medication other than for his hypothyroidism. I have not given them any kind of rescue medicine. He has not had any head imaging done, but he did have an EEG that showed hypsarrhythmia on the EEG. There's been no further laboratory workup. The patient is sleeping well. And my question for you is, I think it's hard to differentiate jerking spells in infants. They do have a nice exaggerated startle. And how do I know when I'm worried about a startle, when I'm not? Is it a startle? And how should I start this workup in these babies? And then as far as his development, he is a little bit delayed in relation to his trisomy, but the family has noted that he doesn't seem to smile as much in the last month or so.
Yeah, I agree with all of you. Jerking spells in babies are really hard. And so the biggest concern is, of course, are you missing something very scary, or are you just missing a normal movement? And so, you know, especially first-time parents, but all parents, they're going to stare at their kid every time they jerk during sleep. You know, we all jerk during our sleep, and babies, it can look very weird. I've seen some videos of normal babies who have normal jerking spells, and it looks scary. I mean, I can understand why the parent's scared. So my first question is, when I hear jerking spell in an infant, is this just normal jerking? And obviously that's a diagnosis of exclusion, but at the same time, it's very real because most of the time that's usually what it is. The next thing, obviously, that we all think about is, could this be infantile spasms? I mean, I think that crossed everyone's mind with jerking spells. And I'll talk about in a second the things I think of this case that make it more or less likely, the things that kind of fit or don't fit. There are also other types of epilepsy. And so myoclonic epilepsy, for example, with the single jerks, could it be a different kind of epilepsy or a different underlying problem? Based on the case that you just told us, I think the 6 months, it's been going on for about 2 months. He's now 8 months old. It started around 6 months. I think that's really concerning for infantile spasms. The part about the head dropping, I think, is a little more unusual. That's not necessarily as classic. The fact that they've increased in frequency certainly sounds more concerning for seizures of some kind. Whether or not it be infantile spasms really depends. Often with infantile spasms, we'll get a history that as they've become more frequent, they've started to occur in clusters. We really don't get that history in this particular case. And I think that makes it a little bit more tricky as well. That's something that I often ask and listen for, and that kind of gets me more concerned when people say yes to that. So I think that's something a little different here. Also, it doesn't sound like they've identified any triggers. And in kids with infantile spasms, it's very classic for parents to describe as they're falling asleep or as they're waking up from a nap or from bedtime, that they'll see more episodes, sometimes with eating as well. And that I don't really get the sense that the family has been able to identify a pattern like that in this case. So that makes it a little bit tricky as well. I think the loss of smiling is very concerning. I don't, certainly if you have normal jerking spells, that, that babies do weird stuff, that's not going to cause regression. This is a very minor kind of subtle regression, but I think it's definitely regression, a kid who's not smiling and interacting as much as they were. And families know that. They know the difference. So that makes me much more concerned for epilepsy of some kind, either very frequent seizures that he's having or infantile spasms. Certainly, obviously can do that as well. So the first approach to any kid that you are worried about has infantile spasms is to get an EEG. If you have a kid that has regular old jerking spells and it's been going on for a long time, it's helpful to capture those jerking spells on EEG. Then we can say, oh, well, the jerking spell was or was not a seizure. In the case of infantile spasms, the EEG itself will be abnormal all the time. After the jerking spells have been going on for about 2 weeks, it will be abnormal all the time. So you don't necessarily have to capture the jerking spell itself. In the cases of other spells, once you've kind of ruled that out, you may need to capture the spell on the EEG. But anytime you're concerned, it's not an emergent issue. It's not go to the ED at 3 a.m. kind of issue, but it is a get an EEG in a week or so kind of time frame issue. And so it really needs to be dealt with. It's not a, we'll worry about this next month when they come back to clinic kind of issue.
Any questions from the audience for Dr. Xixis? They described the head drop, but isn't that kind of the classic falling forward, the salam attacks of the West syndrome?
Yeah. So I think that's exactly what they're describing. I just think the use of head drop is weird and kind of throws you off a little, because certainly kids can have drop seizures as well, or drop type episodes. So I think the use of the word head drop on the part of the family makes it a little bit trickier in this case. But yes, in infantile spasms, they have the classic movements of the arms, either flexion or extension, very quick kind of jackknife jerking, but then they can have the head kind of flexing with those as well.
Even at the waist flexing.
They've been called the salams. Seizures.
What about the baby's trisomy? Is that a high risk for?
Yeah, I don't. You cannot just say, well, a kid has Down syndrome, they're going to have hypsarrhythmia and infantile spasms. And it's not one of those.
But it's more common.
I don't know that it's particularly more common. I know that some literature talks about how a significant number have it, but I think you have to really look at the literature and say, do those kids also have other underlying metabolic conditions or structural problems that are causing it? So I don't know if truly it's more common in Down syndrome as a single risk factor or not. I just don't know.
Ellen?
Yeah, because this mom came to me with, oh dear, I'm in the car, sorry.
You're fine.
Again, Dr. Johnson's on vacation, still, I think this is the first for our echo, is having someone in a car on vacation. It's great.
It started to rain, that's why I came in. But anyway, mom actually presented to me with the spells and was worried about the infantile spasm. To see any in the office, I knew this kid developmentally wasn't quite that good, and we just went for the EEG. And the reason I think I did was because when I looked up infantile spasms, they did say Down syndrome was one of those things that you really should think about. Because from me a video of another kid having an infantile spasm, and he's like, that's what he looks like when he does that. We're talking about
Helen, you're breaking up a little bit. You're breaking up just a tad.
Just the end.
Did you say the mother saw a video online of infantile spasms? She compared that to her child? That's incredible. Yeah, it's available now.
The other thing that's really helpful when I have a kid that is not just a slam dunk, you definitely have infantile spasms or, you definitely have seizures, is videos are so helpful. The videos that families can either bring or compare to, I mean, that's fair, but if they can get a video of their kid doing it, I mean, their explanation is so hard to tease out all the details. And if you can just see it, I mean, it changes the whole encounter. So I always encourage people to capture it if we're not sure. But as a primary care provider, if you are sending a kid to neurology with weird spells of any kind, weird jerking spells, weird movements in babies, if you can encourage the family to video it, that is so helpful. because then we can actually see exactly what they're concerned about.
It's the old saying, a YouTube is worth 1,000 words.
No, it's true. It's true. It's so helpful. It's so helpful.
It's a damn shame. Anyway, any other, Brandon?
Do patients have to have a referral to neurology to get EEG, or can they just order that and be read by you?
Yeah, so that really depends on the area. So I'll talk about here. Every place does it a little bit differently. In our case, because there's only one of me and the wait list is very long, I apologize, you can order an EEG. And I will read it. You will be the ordering provider, so you will get a copy of the report. And the purpose of that, in part, is for cases like this. You know, I don't want a kid 4 months from now to be in a referral pile, which I do go through my referrals, but I don't want them to be 4 months out. They have hypsarrhythmia and we've missed it. So if you're concerned about it, go ahead and order the EEG. If it has hypsarrhythmia, I will find you. I promise.
But, yeah, Brandon, it is in a Mountain States hospital, and obviously Nightwanger is embedded in Mountain States.
Yeah.
What about, you know, Gary Michael up in Clinch River or other areas that aren't part of our network? How can they do that?
Yeah, so that's a really great question and a really great point. From a logistical standpoint within our system, for me to read it at this point in time, it has to be done at our children's hospital in the JCMC in the basement is where the department is.
It can't be done at Outlying Hospital. No,
it cannot be done at Outlying Hospital. And that brings a big issue up because all EEG readers are not created equal, including myself, okay? And where I do get concerned, we actually had a different kid that I had referred for infantile spasms where an outside adult provider had read their EEG, and it was called like maybe spike wave burst versus maybe hypsarrhythmia. We just said, I have no idea what that means. Let's just do it over again. But when we have a normal EEG, it's fine. But when we get into a setting like this where we really are worried that we're missing something very severe, typically the kid will get it repeated if it hasn't been read by a pediatric neurologist, if it's been read by the adult folks, simply because kid patterns on EEG are so different. I mean, in babies, they change by month. In little babies, by week. I have to get a chart out if you're a 33-weeker or a 34-weeker and make sure that everything is correct. And so in adult folks who are used to seeing kind of nice, perfect little lines that all look the same, I feel like we do have some pitfalls with babies. And so if you want a pediatric neurologist to read it, you just kind of need to know, depending on where you're referring them, who exactly is going to be the reader, because it is different and the training for those people is different.
I just want to add something because I just went through this today. Apparently you have to be on a list to order it because I tried to order one yesterday and they refused it. So I actually had to call medical staff today and give them credentials. And after that, it was fairly easy to get it ordered. But you do have to be on a list.
Yeah. I did not know that.
We actually have an EEG representative here. You're off camera. But you want to comment on that?
We've had orders from you in the past, so I'm not sure.
Well, she was a resident.
She was a resident.
Okay.
Now she's out in private practice.
Yeah.
I've never had anybody tell me that they weren't able to order them before. Now, if it's an extended or 24-hour or an ambulatory, that becomes a little bit different because we try to keep that with neurology has been involved in some way. If you have a patient that you are concerned for hypsarrhythmia, please call the lab if they tell you that it's going to be more than a week, because I will probably work you in.
Yeah, she will.
So right now for our area, they need to, the child and family need to come to Nightwanger, and that may change in the future.
Yeah, but for now, that's kind of the setup that we're able to.
Just a couple things. I really appreciate you being in this area because we need it. I have 18 patients I need you to see tomorrow.
I believe that.
All right. Within the field of neurology, is there, in other places, is there a role for telemedicine to some degree? And then secondly, if we're ordering, if we feel that a 24-hour EEG is necessary, is the ordering process the same, or does that need to go through somebody to say, yeah, that's appropriate or not?
Repeat your first question again. I'm sorry.
Telemedicine.
Telemedicine.
Oh,
Yes.
I'm sorry.
Yes, I do think that telemedicine can be very helpful for certain selected populations in pediatric neurology, primarily epilepsy patients that you've already seen, already examined in the past, already know what their MRI shows. The exam really doesn't change what you're going to do. In a kid that has cerebral palsy or a tone issue, something like that, that certainly is something that telemedicine is not going to do as well with. But I do think for kind of follow-ups for epilepsy, maybe follow-ups for headaches if you've kind of ruled out pressure issues, you've looked in their eyes before, at least sometimes, maybe every other or every couple appointments, I do think telemedicine could be helpful. I do.
24-hour EEG.
Yes, going back to the EEG. So because of our limited resources and because of a couple things, how long it takes to read an EEG, they don't read themselves, to read a 24-hour, 48-hour EEG, we at this time do kind of require that at least I've decided that's appropriate, or that they have come through our clinic. I have had one or two providers that had significant concerns. We had a patient waiting to be seen. I certainly understood the concern, and we did a 48-hour ambulatory before we ever saw them, but we had discussed the case and kind of decided, yeah, I do think that's appropriate. And it's really just a number of machines that we have and how, I can't just do that all day. So it's just a resource allocation issue mainly at this point.
If we were to have a non-emergent patient that we would want to discuss with you because of maybe that factor, is there a better way to coordinate as far as speaking with you? You said there's only one of you, and I empathize with that sure, as the only pediatrician in this county, but is there a better way, a better time, a better day?
So I will tell you that a lot of the phone calls that we get now, I have a nurse practitioner now, and she actually does a lot of the talking to outside folks because we do get more calls than you would think in an average day or an average week. And certainly she talks to me about them as well if she's concerned. From our perspective, we have much busier clinics in the morning hours, and so afternoon hours are typically your best shot compared to morning. Morning can be very hectic for us.
And what's the role of your nurse practitioner in terms of answering some questions? Does she field some of those phone calls?
Yeah, so she fields a lot of them. She fields most of them at this point. If they are very basic questions that she's comfortable with, she's been with me almost a year now, and I trained her kind of the ground up in neurology. So if there are very basic things that she knows exactly what I'm going to say, she just says it, or kind of this is what we usually do. If it's a complex issue, like a story where a kid may need a long EEG, that's something she would definitely talk to me about. Or, she may pull me in on the phone call. Sometimes that happens if it is a complex story that she's uncomfortable with. She's very good about knowing when she's comfortable and when she's not.
I want to give you a time to do your didactic. So great questions, important discussion. So which one do I get again? There you go. Okay, I'm just getting instructions from my expert here. And then view, present. Here we go. So just to remind you, this is a CME activity, and we will show you at the very end how to go onto the website and register for CME credit.
Okay, I'm going to try to use this pointer. If it fails, we'll switch. Okay, so we're going to talk very briefly about 3 or 4 common epilepsy syndromes, 2 that we've talked about so far and 2 others as well. There are many others, and in this particular session, we're actually not going to talk about like absence epilepsy simply because there's too many, so we'll talk about some of those next time. We just wanted to have a good amount of time to talk about each one. So, all right, so today we are going to talk briefly about infantile spasms, a little bit more. Lennox-Gastaut, you're clicking me.
I'm sorry.
It's okay.
I was trying to get Chris Calendar. He's now driving, and it's making me nervous that he's driving.
Lennox-Gastaut syndrome, another syndrome called kind of status epilepticus during sleep, which sounds very scary, but is important to know about, not as scary as it sounds. And then benign Rolandic epilepsy, now renamed childhood epilepsy with centrotemporal spikes, but I think all of us still call it Rolandic epilepsy. All right, so infantile spasms first. They are spasms, which the word implies, but they are either extensor or flexor. So the kid can bend forward or they can jerk backwards. The textbook time of onset is around 6 months, plus or minus a couple, that is absolutely not written in stone. So I recently had a new onset 17-month-old. Those are typically called epileptic spasms, but it's the exact same thing and it can happen. So if you have an older kid and you think this looks like infantile spasms, but you're 13 months old, you still need an EEG. Okay, don't ignore that concern. A lot of times infantile spasms are overlooked for a while. People say that they're cute, or they had colic, or they did it because they like to move that way. And so that can lead to a delayed diagnosis, which is unfortunate. We do tend to see these occur in clusters, as we talked about a little bit before, often between waking and sleeping are classic pieces of the history. And when I hear a jerking spell, again, they come in many forms, I try to ask these questions to try to hone in on kids that may have this as opposed to something else. Infantile spasms can be in developmentally normal kids or abnormal kids. So a kid can be completely normal in their developmental history. That does not exclude them at all from this diagnosis. And the cause may be something that we find or that we don't find. It is very hard for everyone, myself included, to differentiate an episode of jerking that really looks like a spasm from one that is not a spasm. And so if you are concerned, you need to take that very seriously. Identifying these kids very early is important to save their development, because even if they were normal to start with, going forward, if this is not treated, they're going to lose milestones rapidly. The classic EEG finding that everyone has heard about is hypsarrhythmia. Hypsarrhythmia is just a big fancy word for a high amplitude chaotic background, and I'm going to show it to you in a minute. It is a generalized epilepsy, meaning that the entire brain is affected at one time. So the people cannot think at all. Their entire brain is kind of scrambled. There is also a entity called West syndrome. That's simply a triad of infantile spasms, hypsarrhythmia on the EEG, and developmental delay. So if you see a kid with that in their chart, they probably are not doing very well, and they've had a history of this that basically did not go very well. So here's a picture on the right of your screen. You should be able to see a 4-month-old EEG. It's a normal EEG where you can see all of the different lines. Each line corresponds to a lead that's on the head when the EEG is done. And then on the left is a hypsarrhythmia patient. And you can see this is actually turned down some. So we can make the lines go up and down on the computer program. And in this particular case, you can tell that the lines are just so scrambled up, you can't even tell which line is which. When you open up a recording on an EEG and it looks like that, you already have your diagnosis. You really don't even need to read the rest of it, okay? So as we talked about, infantile spasms is not an emergency, but it is an urgency. They do need evaluation probably within the week. Often we will end up with a little longer EEG. By prolonged here, I mean it may be 90 minutes instead of 20 minutes. The idea being to see early on when kids first have just started having spasms. It's kind of like the kid that comes to your clinic and said, I started coughing this morning, do I have pneumonia? Kids who have just started having spasms can take a little bit of time for their entire EEG to develop the hypsarrhythmia pattern. And in that case, sometimes we look a little bit longer, and that's kind of at the discretion of the folks doing the study. If we find that a kid has infantile spasms, they are going to get a very extensive workup. The EEG is obviously our screening point to kind of figure out if we need to go down that pathway. The first thing we do is imaging. We're imaging to look for any major structural lesions, cysts, things that explain why the kid is having infantile spasms. If that is normal, then we will go down very extensive serum and CSF testing. Primarily, we're looking for abnormalities of metabolic type stuff, genetic type things that are predisposing them to it. It's not really a good thing for us to find why you have them, because often we are just uncovering that the spasms are a symptom of something else, that really you have a metabolic problem. Often the kids that are going to do the best are the kids that get the workup, nothing is abnormal, they get treated, we clean up their EEG, and they kind of go forward with good development. So infantile spasms are all going to go away, okay? I just said sometimes they're called epileptic spasms because they've evolved into older kids. They're all going to go away, but sometimes they go away because they're replaced by different seizure types. And so some of them then, however, are going to get treated and then do very well going forward. So we're going to transition to the next type. The next type is Lennox-Gastaut syndrome. And this is a syndrome that often the kids that had infantile spasms that transitioned into something else may have transitioned into this particular syndrome. We see this in kids who are younger. So 1 to 8 years old is typically the onset. Up to a fourth of them do have a history of infantile spasms in the past. There's a very specific EEG finding on this as well, which is not something that you would need to memorize for any reason, but there are some specific things we look for. These kids are very delayed. So these are the kids that you see that are on 6 epilepsy medications. They have a helmet. They have 20 seizures a day, even on their 6 medications. That's a Lennox-Gastaut kid. Okay, so these are kids who have very poor developmental outcomes long-term, are essentially never going to be seizure-free. When we think about Lennox-Gastaut syndrome, in addition to the EEG finding, there are multiple seizure types. You have to have at least 2 of the ones I've listed here, which is tonic, so stiffening spells, atonic or dropping spells, and atypical absent, so weird staring spells, but they may have other kinds as well. The drop seizures are the ones that people classically kind of remember and associate with this syndrome. This is just an EEG that shows you, I think you can all appreciate that there are significant spikes in some areas. You see that kind of the lines that are on one certain lines and not on others. Those are essentially areas where the brain is firing off abnormalities that are angry constantly. The space between the 2 green lines is 1 second. So you can see that every second to 2 times a second, this is firing off in their brain. So now we're going to switch to our third category. And this is kind of a bigger picture. There are a couple of different syndromes that fall into this. This is syndromes of electrical status epilepticus of sleep. And this is something I think is very underdiagnosed. I think that it is important for pediatricians, family doctors, ED doctors to know about, because I think it can present us other things and be missed. And this is a syndrome where kids fall asleep, they get drowsy or fall asleep, and they begin to have essentially continuous spiking activity. So their ability to sleep, their ability to have memory, learning is essentially shot. There are different forms of this. Landau-Kleffner is a common classic form, but these others, continuous spikes and waves during sleep, status epilepticus of sleep, they're just different variations of the same theme. They are going to often present in children who have regression. So a common thing that comes up is kids with autism. Do they have epilepsy? Is there something else going on? And usually the answer to that is going to be no. I mean, there's probably something else going on that we haven't really understood at this point. But in terms of epilepsy, I get more concerned about a kid who was speaking fine and suddenly lost their speech than I am about a kid who never had speech. So in a kid who was perfectly normal and lost speech, I do wonder, is there something like this going on? Oh, I can't make it click. Let's see.
Down there on the
Okay. So in terms of which one you call it, it's really not that important. There are certain names that I just talked about which are associated with, if it's more language regression, we tend to call it Landau-Kleffner. If they have more general regression, we tend to call it the continuous spike wave pattern. But the whole point is that they have these ongoing spikes that are not seizures. You're not seeing a kid who's seizing, but they're having nonstop abnormalities on their EEG that is affecting their regression, their development and potentially regression. So as I said, clinically apparent seizures do not always happen. They can have seizures and have this as well, but not always. This is often in kind of the late preschool, 3 to 6 year old age range, kind of the same range where we start to diagnose autism, or hopefully we've already diagnosed it, but kind of in that same category. And that's why I think it's important to know, just to think about, should you have a patient come up that has a little different story than maybe the classic kid. And so, as I said, this is a major source of confusion. People have been incorrectly diagnosed simply because people did not realize they needed to look for this. This is an example. So as I said before, the space between the green lines is 1 second. You can see these spikes. I mean, these spikes are abnormal. Remember the normal one we saw earlier where all the lines were parallel? Here, this is 4 or 5 spikes a second. Often this only happens when they're asleep, going back to why it's so important to capture a little bit of sleep on an EEG if at all possible. And so you can tell this kid is not going to be thinking or learning or memorizing anything very well. And then lastly for today, we're going to talk about benign Rolandic epilepsy. As I said, renamed recently, benign childhood epilepsy with centrotemporal spikes. This onset is between kids who are 7 to 9 years old, so a little bit older. It is, as I said earlier, up to 20% of childhood epilepsies, so that's a lot. These are kids that are developmentally normal. So unlike the 3 conditions we just talked about, where the kid is either not normal when it starts or not normal when the epilepsy finishes, these kids are normal kids. This is self-limited, so these are expected to outgrow this. And it is a focal or partial epilepsy, which is why, as the case we talked about, you can have a kid that has relatively retained consciousness, maybe a little confusion, but they don't fall down on the floor. And some of them actually retain consciousness during the episode. So this particular syndrome is going to show centrotemporal spikes, again, increase during sleep. So if we do not capture sleep, we will not get it. Therefore, these kids are going to have seizures at night. The classic seizure is going to be that they have hypersalivation, so they're drooling, they have speech arrest, they have unilateral movement, either motor changes or sensory changes on the face or in the mouth. So the kid comes in, they stop, they stare, they can't talk, they're drooling, and their face is twitching. That is a classic benign Rolandic epilepsy event. These kids can have generalized tonic-clonic seizures at night as well, but many of them never do. And so that is a possibility, but this right here is the very classic form. The history of this is benign. Most of these kids are going to outgrow it and be perfectly fine. I think there's some newer literature that suggests that these kids have like 5 points lower on their IQ maybe than if they hadn't had it. But in long term, in the big picture, it is not a significant problem. They usually will grow out of it about the time they're going to high school. The workup for this is the history and an EEG. Remember I told you there's a very significant specific look to the EEG that we can kind of hang our hat on. Sometimes because these episodes only occur at night, because the classic episode is this weird kind of I'm stopping and staring and I snap out of it, if the family is okay with it, if the kid is not going to fall down the stairs, and if they are comfortable with what's going on, sometimes you do not have to start anti-epileptics. For kids that have GTCs as part of their presentation, I would recommend starting anti-epileptics. But for a kid who's had 2 or 3 of these episodes in 2 or 3 years, if the family is okay with it, you can talk about the pros and cons of a medicine because we know they only occur at night and we know that they're going to outgrow it. The other very significant difference in this is that you do not have to have an MRI. If you can diagnose someone with this by history and EEG, then we are very comfortable with what that means for that person. And unless they have an abnormal exam or something else that really raises your concern, then you can actually skip the MRI, which is very atypical, obviously, for seizure workup patients. So this is very different if you identify it. And that is it for today. So questions are welcome.
Any questions? We have run out of time. We want to respect that, but any questions people might have? We're getting an echo, and actually the here we go.
There we
go. The ETSU Family Medicine lost their Skype for some reason. It must be their internet access. Well, you know, I want to. Oops. Let's go back to share screen. I want to just. Which one is it again? Oh, there it is.
Right there.
Oh, how do I get out of presentation mode? More? Exit. There you go.
There you go.
I just want to point out the, there we go. This is our website. You can go on to our, if I can get rid of this. You can go back onto our website to get your CME credit. You have to just scroll down. I do want to, we just migrated our website. When you do Google it, you might get the old website, which it won't. It will just say it's not available. And look for the ASPX ending to the website. That's a little technical, but what? ASP?
ASPX is the old one.
Oh, I went on the SPX one. Okay, PHP ending. Yeah, and here's our links. We're going to work this out in the next few days, so you can go back in here. But as far as you can register here for the event to do your get your CME credit, and then there's the materials will be posted if you want to look at the presentation or even the cases. And there's lovely Donna Doherty, our CME planner. There she is. So we want to thank everybody. This is a pilot we're doing. We have these 4 sessions. The next one will be not until January 12th and March 2nd. We are going to be convening an advisory group to go over and then plan a lot more echoes in the future in different content areas. So please fill out your evaluation form or you're welcome to send me an email. I think I'm somewhere in this webpage to send me an email.
And submit cases.
And oh yes, yeah. Please consider submitting cases for other epilepsy conditions or that you might see. And where's the case? Here's the case presentation. Click. You can go on there, and there's the form. You just fill it in, and at the end you hit submit, and we get a notice that you've submitted it, and we can get back in touch with you.
And we are trying to group them into categories in terms of topics right now because we're doing introductory topics. But as we receive other cases that are good cases, but maybe not quite within the topic, we're thinking about doing a session in the future, maybe to kind of incorporate and just talk about those other cases that may not fit into a kind of one of our classic topics. So feel free to submit any case about epilepsy or medications for epilepsy, and at some point we will talk about it.
Great. Well, I want to thank everybody for coming, and thank you to Dr. Xixis and the folks that presented the cases. Thank you very much. Bye.
Thank you.
Bye.
Bye.
Bye. So I can stop recording.